Hello, everyone. Welcome. My name is Claudine Chevrier. I'm a project manager at the National Collaborative Center for Infectious Diseases, NCCID. I'd like to welcome you to this webinar, Conversations about Pediatric Vaccines in the Context of COVID-19. I will be your moderator today. Before we go any further, I want to acknowledge that NCCID is hosted by the University of Manitoba on Treaty 1 territory, the original lands of the Anishinaabe, Cree, Oji-Cree, Dene, Dakota people on the homeland of the Métis Nation. We recognize historical and present harms of colonization, and we strive for reconciliation with all of our partners. NCCID is funded by the Public Health Agency of Canada to support the expanding area of knowledge translation and exchange of infectious disease research for public health. Just a few housekeeping items I want to mention. We're running this webinar on Zoom, as I'm sure you have noticed. So if you have any technical problems with Zoom, you can email us at NCCID. The email is nccid@umanitoba.ca. So again, nccid@umanitoba.ca. The question and answer session today will be focused on today's topic, which is conversations with caregivers about pediatric vaccines in the context of COVID-19. And that will take place in the Q&A tab that you can see at the bottom of your screen. The host will also use the chat tab for extra communication with participants. You might see some messages already, so please keep an eye on that tab as well. And this session is recorded, and a recording will be available after the webinar on our website at nccid.ca. So today's webinar will discuss the constructive discussions, effective conversations with families and caregivers of children on vaccines. Healthcare providers need clear and up-to-date information on vaccine hesitancies and strategy that they can confidently implement in their practice to improve vaccine uptake. The webinar will have two presentations. The first one will be by Dr. Cora Constantinescu and will focus on the challenges to vaccine confidence for caregivers and the strategies to build that confidence. The second one will be by Dr. Olivier Drouin, and we'll look at the ways in which behavioral science can inform conversations on pediatric vaccines with caregivers. Stephanie Elliott will get us started with some context for the webinar. So Stephanie Elliott is a senior policy analyst in vaccine confidence at the Public Health Agency of Canada. Her areas of focus include vaccine science and vaccine confidence knowledge translation for healthcare providers. She holds a master's degree in public health from Oregon Health Sciences University and is a former healthcare provider herself, having been a licensed midwife in the US prior to her career in public health. So Stephanie, I turn the mic over to you.
Thank you so much, Claudine, and thank you to NCCID for providing this great educational opportunity for healthcare providers. I am so happy to be here to introduce this webinar on behalf of the Public Health Agency of Canada. The COVID-19 pandemic and subsequent vaccine rollout has put a spotlight on the long-standing challenge of vaccine hesitancy. This has resulted in a great deal of investment in research on the topic, providing further evidence to inform effective strategies for building vaccine confidence in the public. Many healthcare providers now understand that vaccine hesitancy is generally not the result of a deficit of information, but a complex interplay of many factors. During the COVID-19 pandemic, VAC has strengthened our own vaccine confidence approaches through use of behavioral science insights, media listening, academic research, and community and stakeholder engagement to understand the salient challenges to vaccine confidence and to develop evidence-informed strategies and targeted programming to build that confidence. The ever-prescient Canadian scholar, Marshall McLuhan, coined the phrase, "the medium is the message." The concept that McLuhan was referring to was that the mode of communication is often more important than its contents. 1960s context in which his theory was developed was in reference to evolving communication technologies, but Dr. McLuhan's phrase can be aptly adapted for our current context. The messenger is the message. So while the accuracy and quality of the contents of the message are critical, the weight they are given by the audience, the research has told us time and time again, is determined largely by trust in the source. With this awareness in mind, much of our work at FAC has focused on two major levers acting on this common theme. Research continues to demonstrate that healthcare providers are highly trusted sources of vaccine information. One of our main areas of focus has been equipping healthcare providers to rise to the challenge and support patient-informed patient decision-making on vaccines. Additionally, we know that many, particularly those who've had negative experiences with the healthcare system, turn to community for that information. In 2021, FAC's Immunization Partnership Fund, or IPF, received $45.5 million to support community-led organizations in supporting vaccination efforts across Canada and in identifying new initiatives to increase vaccine confidence, uptake, and access to COVID-19 vaccines. Through the IPF, the Government of Canada has been able to provide diverse IPF recipients the resources they need to support vaccination in their communities. FAC's work to equip healthcare providers to build vaccine confidence during the pandemic has focused on knowledge translation of vaccine recommendations and the science behind them, practical considerations for clinic planning and administration, addressing mis and disinformation, as well as evidence-informed and practical strategies for strengthening vaccine confidence during patient-provider conversations. We have, often in collaboration with external partners such as NCCID and CanVax, delivered this information through a suite of KT products, including webinars and webcasts, the Vaccine Confidence Info Bulletin, and the newly revamped Healthcare Provider Toolkit. We are thrilled today to support another excellent initiative to equip healthcare providers with the skills to build confidence in their patients and clients. We don't really know yet the full scope of the impact of the COVID-19 pandemic on overall vaccine confidence and uptake for routine pediatric vaccines. What we do know is that there has been a global rise in the incidence of vaccine preventable diseases, putting the unvaccinated and undervaccinated children at risk. Measles cases increased worldwide by 79% in the first 2 months of 2022, with outbreaks in countries such as Somalia, Afghanistan, Yemen, Nigeria, and Ethiopia. Given the incredible transmissibility of this virus, measles outbreaks anywhere could be a concern for us all. It is therefore critical that we continue to commit to supporting vaccine confidence within our communities. Every healthcare encounter is an opportunity to build a trusting relationship with the patient or client, to discuss vaccination in a non-judgmental space. However, one conversation might not cut it. Healthcare providers need to position themselves as a reliable, understanding, and patient resource for their patients, ready to return to the conversation time and time again with commitment, compassion, and excellent communication. Having these effective, trust-building conversations is a skill set, and Doctors Constantinescu and Trouet are experts in their respective fields. And the advice they offer here today will be enormously helpful in building these essential skills to support vaccine confidence in caregivers of children. So thank you all for your commitment to the health and well-being of children and to your incredible efforts throughout the pandemic and beyond. I'll now turn it back to Claudine. Thank you.
Thank you so much, Stephanie. So I will now introduce our speakers for today. So Dr. Cora Constantinescu is a pediatrician and infectious disease physician in Calgary, Alberta. From seeing vaccine hesitant patients in clinic to her academic pursuits in vaccine acceptance and surveillance, she has a strong passion for vaccine research and promotion. She holds a master's in medical education and specializes in development and study of education interventions rooted in behavioral change theory. She's applied these skills to vaccine education for healthcare workers and the public and continues to be a vaccine advocate at the local and national level. So thank you, Dr. Constantinescu. I'm gonna let you go first. Thank you.
Thank you very much, and thank you for having me. Let me just make sure that I am sharing. Okay, somebody tapped me on the virtual shoulder if for some reason you're not seeing this the way you expect to see my presentation. So thank you very much for having me, and thanks for the thumbs up, Claudine. I'm going to start off by just telling you about my disclosures. In the past, the last being in February of 2020, I had received honoraria from a number of pharmaceutical companies, such as Pfizer, for example, which obviously has an implication on what I'm going to, on the vaccine that I'm going to talk about. But all these, so these are honoraria I received for continuing medical education for non-COVID vaccine talks I had done just prior to the pandemic. Since then, I have had many talks on COVID-19 vaccine, but I have not received any gifts or money or any kind of remuneration from any pharmaceutical companies or any of the other organizations I've done it for the COVID-19 vaccine. I also am one of the co-investigators on a number of clinical trials that are going on at the Alberta Children's Hospital, some supported by GSK, Merck, or Pfizer, and I am one of the main investigators for a Public Health Agency of Canada grant on actual vaccine confidence and hesitancy around the COVID-19 vaccine. I've also done a lot of work with 19 to 0, which it's a coalition that has received money from a number of pharmaceutical companies, but I have not personally had any remuneration as part of my work for 19 to 0 from any of the work I've done. All right, thank you so much. I'll pass that. We'll move on to the objectives. So really, there are just two big objectives we're going to talk about. One is the challenges to vaccine confidence for parents and guardians for children. As Stephanie very well pointed out, we don't really know what the pandemic and vaccine hesitancy around COVID-19 vaccine has done to other vaccines in pediatrics, but we do know that there's a lot to learn from this vaccination campaign that's been going on for the last year and a bit. And then we're going to also identify some strategies for building vaccine confidence for caregivers of children, again, drawing on some of what we've learned from this pandemic. I don't do any presentation without showing this slide. And this is a slide that talks about the COVID-19 vaccines administered in Canada, and we're at over 85 million doses. And I show this slide, first of all, to remind ourselves that most people are vaccine confident in Canada, as most people have actually had a vaccine. We are seeing, however, a significant gap in vaccine uptake among specialized populations. For example, children, especially those under 12, and then pregnant women are also a significant group that is not seeing the same uptake. And then the other reason I show this slide is to tell you that just by the sheer size of this vaccination campaign, there's been a lot to learn. Now, as Stephanie pointed out, the idea of vaccine hesitancy and confidence is not new. We've known about this for a bit. Hesitancy really is this idea of a delay or acceptance or refusal of vaccine despite their availability. Whereas the confidence is the belief the vaccines work, are safe, and they're part of a trustworthy medical system. However, when it comes to vaccine uptake, vaccine confidence alone, we cannot speak about vaccine confidence alone. We have to put it in the context of disease threat and of overall children's health. It's not just about the vaccine, it's also about what it tries to prevent. And this seems very intuitive, but I'll show you some work that has been done and how we're unpacking that vaccine uptake behavior is not just about attitude towards the vaccine, but how parents view the threat of the disease to their child. I'm part of the advisory committee for Cosmo, which is this. It's a Canada's COVID-19 snapshot monitoring study, and it's supported by the government of Canada. And they've done a number of waves of data collection from April of 2020 to November of 2021, and then it keeps on going. And this is the most recent data that they collected in April of 2022. And they use a panel of 2,000 Canadians, and they believe that this is a pretty representative panel of the Canadian population. I should tell you, though, that what has come out of this latest wave on this panel is that their uptake of the third dose of the COVID-19 vaccine is higher than the general population. And that's a flag that this panel may be maybe a little bit more confident towards vaccines than maybe the general population. And this is really key because of what I'm going to tell you next. So, in this population, the panel, when they asked those who are parents of unvaccinated children 5 to 11, so these are children who have not been vaccinated in the 5 to 11 age group, we know that about so depending on the province, somewhere between 40 to 50% of those children are unvaccinated in Canada. So of the parents of those children on the panel, 92% indicated that they do not intend to vaccinate their children, making it seem like it might be a done deal in terms of the 5 to 11 age group and COVID-19 vaccine. Similarly, if they were parents of teenagers, so 12 to 17, interestingly, if they had had 1 or 2 doses, 41% of them would actually give a third dose to the teenagers, and 31% would not vaccinate the children with a third dose. And then obviously we're just on the potential verge of authorization of the vaccine in those under 5 years of age. Tomorrow, the FDA is meeting to discuss this in the US. In children under 5 years of age, so 0 to 4, 41% of parents would vaccinate their children as soon as possible. And the way that breaks down is 31% would vaccinate right away, and then 10% would wait a bit and see after a time. And then 48% would not vaccinate the children under 5. And this is very similar, a bit lower than where the uptake, where the intent was in the 5 to 11 age group. So it's interesting that of those, so the percentages match the general population in terms of the unvaccinated in the 5 to 11. But most parents are saying in the 5 to 11, if you have not vaccinated children already, 92% say they don't plan on vaccinating. So here's the interesting part to me that was a bit of it makes you think, is this next slide. So when they asked the same cohort what their source of information and trust was, the vast majority indicated a great deal of trust. So 4 to 5 out of a 5 scale of trust in healthcare workers and scientific experts. They also trusted the federal government and provincial governments relative to other sources such as family and friends. So this is interesting because we have a cohort that is actually quite quite trusting of healthcare workers and scientific experts and government, and yet would still not vaccinate their children. And when they asked the question of why, the top reason by the vaccine hesitant parents was they felt that children are healthy and the immune systems will protect them. Bringing in the idea that it's not, we knew that it was not about correcting misinformation, but it's also not just about building trust. And there is that component of complacency, or rather feeling that the disease is not the threat that it is to the child. So keep this in mind as we discuss some of the strategies that we can actually employ. Overall vaccine hesitant parents, and this is work that has been done by other groups, and also we went and we asked our own vaccine hesitant parent clinic, the ones who come to our clinic. We did a qualitative study and we asked them how what their attitudes were towards the vaccine. And overall, they feel that children are not at high risk of COVID-19 complications and may feel that kids have already had COVID-19 and have natural immunity. And that lovely unicorn is every parent's dream, right? That your child has had it, hasn't had any bad effects, they're doing really well. The other thing, and this has also been amplified by the pandemic, is that parents draw on their lived experience. So now remember that we have over 85% of parents having had, of our population having had a lived experience of having had the vaccine themselves. So lived experiences that seem to be correlated with uptake were a negative interaction with healthcare providers in the past. So this may or may not have to be about the vaccine, a negative experience with the vaccine in the past, and they may have not had the vaccine themselves. So this lived experience is a really important component to consider when we talk about vaccine uptake to caregivers. You've probably seen this a lot before, that the main three C's of vaccine hesitancy as put out by the WHO are confidence. So this is related to the vaccine. Do I believe the vaccine works? It's safe. Do I trust the vaccine, the pharmaceuticals, the government, and so on? And then this really big category is that of complacency. So this perceived low risk of severe disease in the child. And Omicron has had an interesting effect on all of that and perceived low risk of severity. And what's really interesting is this idea of exceptionalism. So we see a lot of this in our parents, and we used to see it with the other vaccines, and we're seeing it with COVID-19 as well, is that they believe their child is not at risk of the disease, or if they were to get the disease, they're not at risk of the severe complication, but somehow their child is so exceptional that they might have a severe side effect associated with a vaccine. This kind of like exceptionalism in both ways. And it comes around this idea of complacency and this balance of the vaccine risk versus the disease risk that seems to have played out significantly over the last few months as our hospitals have seen a huge surge in the emergency department of children with COVID coming into the emergency department. We've had the highest hospitalizations with the Omicron wave, and yet still this is still perceived by parents as an overall not a significant threat to their children. And the big thing also was convenience. So how available was the vaccine made to parents and to children when it first came out? And I would say that with the exception of a few provinces and territories, this issue of convenience or accessibility was not well done in a lot of other places. And when accessibility is a problem, it becomes an equity problem. And we certainly saw that across different jurisdictions, different places, even within the same city, that we had different groups not be less protected than others because of issues with accessibility of the vaccine. If you were going to just break it all down to what the message around vaccine confidence is, and you're going to say, well, where's the one slide that's going to kind of bring it on and say, well, what should I talk about, is you have to approach the vaccine from a personal protection perspective. And I know I've said this over and over, and some people might have heard it over and over. It's about personal protection. It's not about herd immunity, protecting others. It's about the child being protected themselves. That's the message that resonates with parents. And then this idea about complacency. So it's not just about talking that the vaccine is safe and is and that there's trust in the vaccine, but also putting it in the context of protecting this child from a vaccine preventable disease with this safe vaccine. And remembering that healthcare workers before the pandemic were the most trusted source of information on vaccines, and even post-pandemic, well, during pandemic and post significant waves, we're still the most trusted source of vaccine information. So this hasn't changed, which is also really interesting and reassuring to me to see that people still trust us as their main source of information. So there's a lot of power and that comes with the ability to hold this conversation with parents, which is why it's so important that we do it and that we make the recommendation for the vaccine. But this is also a tough time because a lot of people have reached a certain level of advocacy fatigue. Everybody embraced the advocacy of the vaccine when it first came out. And it's been really tough over the last bit to still keep that same enthusiasm going. There's been a lot of people feeling guilty about maybe missing opportunities with their patients, a lot of anger, and just over a lot of confusion as Omicron comes, as we vaccinate a number of our as we've infected a number of the population. People are saying, well, what is there still a point in the vaccine? Is there a point in the boosters? When should we give the boosters? There's a lot of confusion in even among experts around it. So I just want to acknowledge that all of this is present, and we as healthcare providers have to deal with all of this on top of a lot of changing and difficult information. If you're going to look at this from a behavioral lens, and Dr. Drouin is going to tell you much more about this, but we've done a little bit of work on this as well. And the three main, if you look at behavior as a factors associating capability or skills or knowledge, ability, opportunities, or the chance to change a behavior and motivation to change the behavior, there are some things that we have learned, I think, over this pandemic, that we can apply moving forward to other childhood vaccines. The first one is access. Access is so important in terms of having the ability to say to parents, it's really easy to get a vaccine. And I still maintain that this was done not as well as it could have been done when the initial vaccination came about in children. And if we had improved access, we would have made this vaccine as the norm, which and make it as part of the vaccination schedule, considering the fact that COVID, at least, till it's still one of the most significant vaccine preventable viral threats to our children. And pain mitigation, and we'll talk a little bit about that at the end, is also an important component of changing capability. So giving a sense to parents that there is something within their power that they can do. And opportunity is really important. So we've reached this vaccination fatigue. There are previous negative experiences, and then this natural immunity myth. And we're seeing now more and more with Omicron, we're learning that Omicron alone infection without having had vaccination or other strains infection is nowhere near as good as this hybrid immunity or even immunity from previous strains. So we are going to be looking at a waning immunity, and we don't really know how that's going to shape in our population. And then, of course, this motivation. So kids don't have to die in high numbers, and they don't have to overwhelm the healthcare systems to deserve protection against severe disease from COVID. And this is where the motivation is to shift a bit, especially in light of Omicron. We're not trying to prevent infection anymore, at least not with the current vaccinations, but we are trying to prevent severity. Connecting before communicating is really important. And I say this to a lot of people. If you don't feel you have that connection with the parent in front of you, then it's probably not going to be the best opportunity to talk about the vaccine. And showing true curiosity and meeting people where they're at, but also establishing the vaccine as the norm. This is not some kind of a nice privilege that people can have. It's actually the norm of what we have a vaccine preventable disease in terms of severe COVID. We have a vaccine for it, and this is now part of the vaccine, the norm of the vaccine children's vaccination schedule. And often people come with different ideas about the vaccine, but the emotion is always there. So whereas you may not always be able to validate the information, so you may not be able to validate the stuff they may say, such as, I believe the vaccine causes infertility. You cannot validate that, but you can validate the emotion, the fear behind the message, which is always really important to do, and keep it really personal. And we'll talk a bit about a framework on how to do that. And then exploring the past history is important. So looking at negative or positive interactions with healthcare providers, their own cultural trauma, and then also their perceived personal contraindications to immunization. So a lot of people come in and say, well, I've had a reaction to the vaccine and I'm worried that my child's going to have the same. So there's this perceived contraindication that's not actually a contraindication, but a lot of the vaccine hesitancy of motivated people comes from that. And personal health benefit is what the focus of the message should be on, and then aiming for a positive interaction. So even if at the end of the day you haven't passed a lot of messages along, as long as you've had a positive interaction with that parent, that goes a long way in terms of being a facilitator for vaccine uptake further down the road. And some of you have seen this communication framework that we've put forward. It's called Protect. And this is a bit of a combination of presumptive statements and motivational interviewing, and how to put it together for a short conversation. So this is to maintain a conversation with somebody about the vaccine. It's not necessarily to not necessarily for the vaccine hesitant, but you start with a presumptive statement. So instead of saying, have you had a chance to book the vaccine, you'd say, how did the vaccine go? Which is you presume that the vaccine, you're setting the vaccine as the norm, and you're presuming that this is what's expected of that interaction. And also you're setting the tone right off the bat that you're not there to debate the vaccine. Your aim is to help them get the vaccine. And then the next part of protect is the offer to share your knowledge about the facts and experiences that people have had with the vaccine. And this is where the motivational interviewing comes in, using the open-ended questions, affirming and reflecting and summarizing. This is where you're asking, letting them tell you about their experience in the past or their fears around it. And then really key to tailor the recommendations to the specific health concerns. It's tempting to talk about something but really important to just tailor it to what they come in with and address that specific concern, and always bring it back to the patient. So this is a very personalized, it's all about that patient and that family versus some kind of a philosophical debate that you could be having. And I always end every conversation, no matter how it goes, with a plan. So I talk through a plan of what is going to happen next, or what I think should happen next to them. And those slides are included, and you can look through them. And then for the last minute, I just want to talk about the commitment to comfort principles. And this is from the Solutions for Kids in Pain, a wonderful website. They have a lot of resources. But don't underestimate the perception of pain and fear, even in children who don't necessarily tell you that they have that fear. The vaccination is still a big deal for most of the kids. So creating a comfort plan, and this is important to talk through with parents, because then they have some tool they can use. So ask the person being vaccinated what their preferences are. Do you want me to hold you? Do you want to sit down on your own? Do you want to watch something on your tablet, or do you just want to watch the vaccine being put in? Use numbing cream. Again, it gives a sense of control, even though obviously it doesn't get rid of the pain of the actual intramuscular injection. And simple positive language. I love how you're relaxing your arm. I talk about what they did well and what went well, because you're setting the stage for subsequent doses. And use comfort positions. So, do you want to be held? Do you want to stand upright? Do you want to lie flat when you get the vaccine? And shifting attention is important as well. And that can be deep breathing, music, electronics, and so on, to shift that attention. But thank you, and I will pass it on to Dr. Drouin from here.
Thank you so much, Dr. Constantinescu, for this presentation. Lots of good information on strategies there. I just want to note that we are keeping track of the questions that are being put in the Q&A tab, so they're not getting lost, and they will be answered at the end of both presentations. So I am pleased to introduce our second speaker, Dr. Olivier Drouin. Dr. Drouin is a clinician scientist and general pediatrician at the CHU Sainte-Justine in Montreal, Quebec. He's also a clinical associate professor in both departments of pediatrics and the Department of Social and Preventative Medicine at Université de Montréal. He completed his medical training at McGill University and Université de Montréal, and earned a master's in public health from Harvard T.H. Chan School of Public Health. His research expertise is behavioral sciences and their application in general pediatrics and public health. He also pursues research in health service research, patient-centered outcomes research, and health economics. His themes of research include adherence to medication, health promotion, and more recently, COVID-19. So Dr. Drouin, I'm looking forward to your presentation. Thank you.
Great, thank you very much for both the invitation and the kind introduction. So we're just going to dive right in with my conflict of interest. So I'm both with regards to COVID-19 as well as other project. I'm a principal and co-investigator on the numbers of Canadian Institute for Health Research funded projects. I was also a co-investigator on an investigator-initiated project funded by Covis Pharma, which has no relationship to the current presentation. And I received an honorarium for speaking engagement from professional organization as well as the CBC. So none of that is bearing to what you're going to hear next. So what are behavioral sciences? So behavioral sciences are a group of disciplines interested in understanding how people think and behave. And to most people, that means psychology, but also it means more than that. This also includes economics, law, policymaking, and increasingly public health specialists and healthcare workers. And really, behavioral sciences are interested in understanding how people think and how they behave. And how some ways of thinking may be very effective in one context, yet be maladaptive in another. One of the most well-known concept of behavioral science is the system 1 versus system 2 thinking. Some of you might have read Thinking Fast and Slow by Nobel Prize winner Daniel Kahneman. But this idea that like we have two ways of thinking, one that is automatic and rapid, system 1, and the other one that's slow but accurate, system 2. And so that's one example where, you know, it might be very helpful to be in system 1 sometimes, it might be helpful to be in system 2 sometimes, but if the type of thinking is maladaptive to the situation, that can lead to problem. And, you know, that's one example of behavioral science being applied as you know, very general way that people can think, but it can be applied to multitude of contexts, including medicine and public health. Another prize winner is this gentleman, Richard Thaler, who said, summarized it quite well, said, "People aren't dumb, the world is hard." And I try to remember that. And because when I interact with people, I look at the world and I'm puzzled by how people react and act. And that includes vaccine hesitancy. For many of you who might be very convinced about the evidence or the need to vaccinate, it can be quite puzzling, you know, frustrating to try to understand some of our parents' behaviors. But my humble goal for today is to give you a glimpse of what behavioral science can provide with regards to vaccine hesitancy in two different directions. The first one is just plain understanding where people are coming from. And second is, you know, using the toolbox of behavioral science to be more effective at promoting vaccination. And so, you know, I think it was mentioned by Stephanie earlier that, you know, a lot of people still, even though it's quite passe, but a lot of people still approach vaccine hesitancy as an information problem. If only we would give enough information, or people would just get enough information about how great the vaccines are, they would just be convinced and take it. The reality is that in an information-rich era like the one we're now, it's rarely the case that the source of information or the amount of information is the problem. It's much more often a difference in way of thinking. And I'm of the school that of thinking that, you know, creators of willingly anti-vax messages and this sort of information are actually not stupid. They're actually very smart. They are just, you know, in the other camp, and they exploit cognitive biases that we all have. They just manage to tap into very intuitive and very sensitive way of thinking, and they just exploit that for their own benefit. And we need to understand that and to recognize that and to be able to more actively fight it. I'm going to talk about quickly cover 4 types of cognitive biases or cognitive mechanisms that are at play with regards to vaccines. Those are over-optimism, social norms, confirmation bias, as well as identifiable versus statistical victims. So over-optimism is basically is the fancy term for what Dr. Constantinescu referred to as complacency. This idea that like my child is not at risk. This is not a COVID study graph that I'm going to show you, but just show you, the same could be true about COVID. This is a study we did with a colleague of mine looking at just asking parents of children whether they think that their child is, how likely their child is to start using tobacco, cannabis, or opioids on a relative scale. So compared to the average child, is your child much more likely, as likely, less likely, or much less likely than average? And obviously at a population level, we would expect this to be most people to answer as likely as the average, because the average is composed of average people. Yet when we ask people, you can see that the overwhelming majority of parents think that their child is at least less likely, if not much less likely than the average child to start using those substances. And so that's the exceptionalism that Dr. Constantinescu was talking about. People just think that their child is special, and that the risk that other people are exposed to is somewhat different. It's those rose-colored glasses that people wear, especially when it comes to negative outcome of illness, for example. Social norms, another one that might ring a bell to you. Social norms are this idea that when we're not sure what to do, we look at what other people do, and we do the same. And in some contexts that might be useful if you're taking the train in Japan and you're not sure where to go and how to buy a ticket. Looking around you and doing like other people are doing is probably a fair guess as to the right way to do it. The problem is that we do the same thing about opinions, for the better or for the worse, and sometimes we do it consciously, but very often we do not do it consciously. And so when we're not sure what to think of an issue, whether it's cryptocurrency, COVID vaccines, we just look at people around us, either physically around us or in our social networks, see what they say, what they think, and we tend to adopt a similar point of view. And that also obviously blends with identities. As you're part of a group, the cost of having a different opinion than your peers is high. And if you show any kind of doubt or any uncertainty about, gosh, what do I know about COVID vaccine? Should I get it or should not get it? Then you will, you'll encounter many people who will be glad to give you their opinion. And if you have enough people in your entourage, having a very strong opinion one way, you're more likely gonna adopt this point of view yourself, even though it might not be the right thing overall for you personally or for your child. And this is the reason for clustering of several behaviors. It's definitely true of smoking, but it's also true of vaccine hesitancy even before COVID. There's definitely hotspots around the world of vaccine hesitancies, and they probably have less to do with who lives there than like how people are connected and the kind of social norms that's created locally. That obviously echoes what I'm going to talk next, which is confirmation bias. So confirmation bias and is close relative echo chambers. We've always, since the dawn of civilization, we've always surrounded ourselves with people who think like us. It's just so much more prevalent and so much easier to do with social media. I can easily only follow on Facebook and Twitter people who think like me, and then just block or plain ignore people who have a different opinion. And obviously that reinforces our belief, because if I open my social media feed today, I will have a tailored view of the world that's going to just reinforce what I've already been thinking about. And I just get more and more ingrained in my point of view. And in that environment, it becomes really hard even for well-intentioned individuals to have to hold moderate points of views. And that leads to an outweighed influence how we look at even plain scientific evidence. And it is the reason why two people can look at the same evidence and come up with two different interpretations. And I've been, unfortunately, victim of that. We, at the, I think about a year ago, we published this paper in Canadian Medical Association Journal looking at, among, during the first year of the pandemic, looking at how many kids actually got sick enough from COVID-19 to be hospitalized, and what was the outcome of those individuals. And just to give you a 30-second context, this is the main findings. What we saw, which is that over a 9-month period, we had 150 kids who were sick enough. So that's like first, second, and part of the third wave. 150 children who were sick enough to be admitted in the 17 children's hospital across the country. 32 of them, so 21% needed to be admitted to the intensive care unit, and a handful of them required breathing assistance. And when we published a paper and we disseminated the findings, we got a lot of heat from actually two very different crowds. So on one hand, people who typically were opposed to public health measures and to vaccines cited our paper and said, hey, look, like there are very few children who actually are getting sick from COVID. So we shouldn't, they're immune and we shouldn't do anything about it. And we should definitely not push vaccination this group. And then the flip side is that people who were really anxious about COVID looked at the same papers, same evidence, the same table you're seeing there, and said, hey, look, like they're like children who ended up in the ICU because of COVID. We should definitely like push vaccination. And so you can see that like depending on the point of view that you bring on the table, you might interpret the same data very differently. And I think that brings home the point that like information is not enough, because depending on where, the way that you think about the problem influences a lot how you look at the data. The other thing is very important. We talk about, Dr. Constantinescu talked about personal stories. One concept is the identifiable versus statistical victim. I've read that somewhere that, Joseph Stalin is reputed to have said that the death of one person is a tragedy, but the death of 1 million is a statistic. And conversely, Mother Teresa once said, if I look at the mass, I will never act. And I tend to say when Stalin and Mother Teresa agree on a point, I sit up and I pay attention. All that to say that like, in the first couple of weeks of the pandemic, we all knew how many people were getting sick, how many cases there were, and how many people died. Whereas today, unless you Google it, you probably wouldn't remember what are the latest numbers. And the same thing happened with this photo that you probably all remember from the Syrian war, where there were like, tens of thousands of refugees trying to run away from Syria, but it really took like this one photo of this one little boy who drowned in the sea to make a huge movement come together to finally help those refugees. And so what does that have to do with COVID and with vaccination generally is that, as Dr. Constantinescu said, just the stories are very powerful. The individual and the personal message resonates a lot with most people. The stories can be yours, but don't have to be. It can be about your patients who got sick with a disease that is vaccine preventable, or it could be from patients who cannot get vaccinated because of immune deficiencies, for example. But those personal stories and being able to put for the families to be able to put a face on the other side, that can help a lot in convincing and moving the needle on this hesitancy. And that brings the facts versus feelings dichotomy. The classic phrase about facts versus feelings, that's facts don't care about feelings, but I would argue that often feelings also don't care about facts. And the hardcore anti-vax will probably never get their child vaccinated because of a good argument, which brings the point that what do we do moving forward? And we touched upon this in the last presentation, but most people go in a conversation or any argument aiming to win, like somewhat convince the other side with like key argument that people cannot argue against. Yeah, I would urge you to go instead with compassion. Be curious, genuinely ask questions, try to understand where the other person comes from. They might well be good reasons for the other person's point of view, even if you agree with them. And it doesn't mean you need to agree with the other person, nor nuance your position, but at least you're going to be, you're going to be better equipped to have that conversation, and B, it's just going to be more respectful, and you might learn something about that person or about the best way to convince them. Now, as of now, like 2 years in the pandemic, if most parents walking in your office probably already know what your stance on vaccine is, and if they choose to talk to you about it, and they're opening the door, so just don't shut it close in their face. If you're good with them for the first time that they have a discussion, you can probably be sure that they won't breach that topic ever again with you. But if you do listen to them, the hesitant parent may come back with more questions on the next appointment, and eventually be convinced. And as I was said before, think of those conversations as an investment, a long-term relationship, rather than trying to win some kind of fight the first time you have the conversation. And the last point I would make is protect yourself. We talked about advocacy fatigue. Remember that you're not responsible for all the polarization, misinformation, conspiracy theories flying around. It's not all on you to take. It's okay to try to do the right thing, but it's not better if you burn yourself out and then you're not there to advocate and to be there for your patients. If you have an angry extremist conspiracy theorist in front of you, it's okay to take a pass. It's okay you're probably not gonna convince them anyway. In my opinion, it's better to keep your energy for give factual information and to people with legitimate question, incomplete or false information that can be corrected. You're probably going to go further in doing good. And yeah, so I would suggest listen, be curious, correct information. I think the other point was normalize the vaccine. I think it's a great point. And that's it. So I just want to acknowledge my funders, and I'll be happy to take any questions.
Thank you so much for that presentation. Thank you to both of our speakers for your presentation. So we will now move on to the questions and answers period. I want to remind you that we are using the tab for this part of the session. So that's the Q&A tab, that's the bottom of your screen. There's already some questions there. I also want to say that if you have submitted questions when you registered for the event, we also have those questions so they didn't get lost, and no need to ask them again. We'll try to get to as many questions as we can, prioritizing, of course, questions that are relevant to the topic at hand. If you want to, you can like other people's questions to put them up in priority. And again, we'll try to answer as many questions as possible in the time that we have with our speakers here. All right. So the first question I'd like to start with is one that came in. I really like your point about stories. Would you be willing to give an example of a personal story or the story of a patient that you have used in your practice?
Is the story, the question goes to me, or?
I think you both mentioned personal stories, but yeah.
I'll go first. Now, Konstantinescu can complement. Yeah, I think I've one thing that I didn't touch in the webinar, but that's pertinent also, is the idea of regret. I remember early in the pandemic when vaccines were not available, I was working in on the COVID wards. So we were the referring center across the province for children with COVID. And I'm unfortunately the clinician who was the first to send a child to the intensive care units in the entire province. And, it was dramatic and traumatic experience for the family. And I do bring this up. I'm like, yes, it's true that, most children who get COVID are okay, but some of them do get sick enough to go to the ICU. And if you talk to those families, as I did, if they would have had back in the days an option to protect their kids around having to go to the ICU, having a breathing tube down their throat to help them breathe, I'm sure they would have taken that option. So that's the kind of, without going into the details, I think it's something that resonates and that helps families put themselves in their shoes. I'm not trying to make them feel bad, but I do want to share the reality of some of the families who unfortunately did have negative outcomes. So if you have any, or the other type of population is obviously the leukemia patients or the transplant patients who cannot get vaccinated, or can get vaccinated but has poor response to the vaccine. That's another example that can be used depending on the person's practice.
Thank you. Thank you for that answer. Dr. Constantinescu, would you like to also answer?
I have a lot of personal stories. Because I'm an infectious disease specialist, I think we see a lot of the tip of the iceberg. Like we really do see a lot of these kids getting really sick. We've seen streptococcus pneumoniae and all these things that people forget about. But I have two. So one is I was involved with a little baby a few years ago who died of whooping cough. And it was traumatic for everybody, and everything had been tried to save this child, and at the end of the day the baby died. And I remember and I had a 1-year-old at home at that time, and I remember sitting in the main lobby of the hospital and seeing this parent whom I had met. This is the one who's lost a child, walking out of the hospital with an empty car seat. And I think it's, as a young parent myself at that time, a parent of a young child, I remember thinking, can you imagine walking into the hospital with your child in the car seat and then driving home with the empty car seat? And I think sometimes parents, forget that this can happen. It's rare, but when it does happen, it's devastating. And then the other story that I have to say is I was on call. This is much more recent. And then I got called to the hospital because they had a very, very sick child with COVID. This was a child under 5 with COVID, whose parents had been fully immunized. The child, however, had not been. Child ended up in ICU, almost close to the point where they had to bypass the lungs. So they were very, very sick. And I remember the parents looking in, and this poor little body with a group of people around them, doing all they can to save this child's life. And I remember looking at these parents trying to keep it together. And then, this is a happy story because this child, despite about a 2-month hospitalization, did end up walking out of hospital. I saw them in follow-up, and the parents did say to me that at the same time this was happening, there was this whole protests going on in Ottawa, and they said it had all of a sudden it was so personal. And if we just remember that when we talk to parents about the vaccine hesitancy, is that it's not personal until it is, and then it's just it's so traumatic and it marks you forever. And I tell you the stories to remember that every time you have an interaction with a parent, you have to keep it personal, because as a parent, you don't want it to be personal. As Dr. Duen mentioned earlier, you assume the best for your children, and it's our job to remind parents, not to scare them, but to remind them this does happen to some children, this does happen to some parents, and you have to keep that conversation about that child.
Thank you. Thank you for these great stories. We received a few questions on a similar topic, so I'm going to kind of mix them together. It relates to so this one person in the Q&A tab said that, thank you for the presentations. They were very insightful. As part of public health program to increase vaccine uptake and confidence, we've held education sessions for parents in the past, but we never found it was helpful or changed their mind in favor of the vaccines to protect their children. More often than not, parents will stick with their decision not to vaccinate despite all the available evidence. How do we approach a situation like this? So there were other questions like this that say, if people already have their mind made up when they walk in, what can we do?
Yeah, I mean, I'll go. I think I think it's not that information is not helpful. I think it can be helpful. Getting the facts straight is prerequisite, but it's not sufficient. So so that's part one. Part two is that even if you move the needle on a few parents, I think it's still valuable. I think the third thing to remember is that this personal connection, the trust with the healthcare system, and that trust with and that relationship with a given healthcare provider can also move the needle. And the fourth thing is that you never know when people walk in, they might be, from one day to the next, from one moment to the next, they might be in different mindset. Maybe they've just heard about their neighbor's kid being sick with COVID, and the previous 3 times that they were exposed to that information, they didn't quite resonate with them, but for some reason today it does. So I don't think I hear the difficulty and the frustration about, we do all of this and it doesn't work. But I think you need to remember that it, sometimes it does work, and you don't know when it will, but it definitely does. And that's how those efforts unfortunately are. And that's what public health is about, unfortunately. But we need to keep at it, because definitely we're moving the needle. And given that, 85-90% of Canadians got at least a shot, like, we're doing something right. So I know we're focusing on we want to reach that 100%, and that's a laudable goal, but I think we need also to remember the goods that we're doing.
Dr. Constantinescu, did you want to add anything? I saw you moving.
No, I thought that was a fantastic answer. We often get this question from our emergency medicine colleagues. They say, I see this patient, they're not immunized. What can I possibly do? And it goes back to, if you don't have a previous trusted relationship, it's hard, but it's not hopeless. And focus on that positive interaction. So even if you're just listening to their concerns in that moment, that's a positive interaction, which later down the road might translate into vaccine uptake.
Thank you. I'll sneak in a last question because I think it's very interesting. It relates to the COVID vaccine. What are ways and topics that we can start communicating with families about the pediatric vaccine under 5 before approval by Health Canada as a way to prime them? I'm wondering if either of you have any insight on that.
I will just share. So one of my fantastic colleagues, who's an epidemiologist, has just looked at seroprevalence. So like how, and this is all in Alberta, and I don't know the story across Canada, but I tell you, there were a lot of infected children in Alberta. One way to start the conversation is that everybody assumes that everybody has had Omicron. But what I learned from his presentation, and this is Dr. Jim Kellner's to us from the data, and he hasn't published his data yet, but this is robust data that they've obtained from seroprevalence studies, is that somewhere around 40% of unvaccinated kids in the 5 to 11 age group, so even more so in the younger age groups, have not had Omicron, and they have not had COVID. So this assumption that your child is all good because they've had it is actually not true. And I would start with that, planting the seed and the idea that this isn't over yet for children, especially those unvaccinated.
Thank you so much.
I would say just have some facts ready about what does it do and not do. What is the real efficacy, the reported efficacy of the vaccine, like knowing how many kids got sick from it. And I think acknowledging the fact that it's not the most pleasant hour of your day to get yourself vaccinated. They're acknowledging that there are some questions and there are some concerns, but also putting it into context, I think is a nice way to start.
Thank you. Great answers. So thank you again. Sadly, I think that's all the time we have. We were already over time. So thank you so much for the presentations. Thank you for our speakers. Thank you for everyone for joining the webinar. We hope that the information provided is relevant to your work moving forward. I want to say that the recordings for the webinar will be available on the website as soon as possible. And as soon as you log off the webinar, there will be a short evaluation that you will receive. These surveys are really useful for us to plan future events. So please take a few seconds to fill it. It's really short. Thank you again to our speakers, our participants, everyone who helped make this happen. And I hope everyone has an excellent day. Thank you.